Welcome to AETCM, the Emergency Medicine channel. Today, I will be presenting the case of a 60-year-old male hailing from Thrissur. He is a retired bus driver. He presented with complaints of cough since one day and blood-tinged sputum since one day. History of presenting complaints. The patient, who was apparently normal, presented with cough since one day. The cough was sudden in onset, productive in nature, no postural diurnal variation noticed. The expectoration was mucoid in nature initially, scanty in amount, not foul smelling, no diurnal or postural variation. He noticed 5 to 6 episodes of blood-tinged sputum following bouts of cough, and 1 to 2 episodes of blood clots were also expectorated in sputum. No history of fever or evening rise of temperature. No history of chest pain, palpitation, syncope, breathlessness. No history of any recent weight loss, loss of appetite or night sweats. No history of orthopnea, paroxysmal nocturnal dyspnea. No history of hoarseness of voice or difficulty in swallowing. Past history. He does not give history of any similar episodes in the past. He is a case of sputum-positive pulmonary tuberculosis initiated on anti-tubercular therapy since 26th of March 2024.
So the duration is over 6 months over?
No sir, he is still in the continuation phase of treatment. The repeat sputum AFB staining done in July was found to be negative. He is also a known case of type 2 diabetes mellitus on OHAs since 4 years and history of coronary artery disease post PTCA in the year 2018. No, he does not give any history of obstructive airway disease or other pulmonary diseases. No history of hypertension, CVA, CLD or CKD. Family history, he is born out of a non-consanguineous marriage. He has 2 children. No history of pulmonary tuberculosis among the family members. There is no family history of malignancy also. Personal history, he is a reformed smoker with a pack years of 40 years. He follows a vegetarian diet with normal bowel and bladder habits. He gives a history of firewood smoke exposure in their house. Immunization history gives a history of taken vaccination for COVID and no other, he is not able to recollect any other immunizations taken. Treatment history, currently the patient is on 2 tablets of fixed daily combinations availed from the nearby health center on a daily basis. He is also on antiplatelets tablet clopidogrel 150 mg for CAD and on OHAs tab glimepiride for type 2 diabetes mellitus. From history, a 60-year-old male who is a retired, known case of coronary artery disease, type 2 diabetes mellitus and sputum-positive pulmonary tuberculosis, presented with complaints of sudden onset productive cough associated with multiple episodes of blood-tinged sputum and blood clots in sputum since one day.
What do you think? What is the reason for hemoptysis in this patient?
Sir, since he is a case of pulmonary tuberculosis who is undergoing treatment, the most probable cause could be a sequelae of the tuberculosis. Other than that,
Sequelae means what?
Sequelae is an event that is happening during the treatment of.
That I understand. What sequelae?
Sequelae, possibly a cavitation can be considered in this patient.
Cavity with bleed into the cavity.
Bleeding into the cavity.
What is Rasmussen's aneurysm?
Rasmussen's a dilatation of the bronchial artery, which
inside
can may also
cavity. It can bleed.
It can bleed.
There is a commonest cause for bleeding into the cavity and hemoptysis. Okay.
Examination. Moving on to examination, he is conscious, oriented, moderately built and poorly nourished.
Before going to the examination, what are the steps you should avoid in this patient in examination?
Percussion should be avoided.
Okay.
Moderately built and poorly nourished, the height of 154 centimeter, weight of 45 kilogram and a BMI of 18.5. No clubbing, lymphadenopathy, pallor, pedal edema, cyanosis. JVP was not elevated. Vitals, heart rate was 78 beats per minute, regular in rhythm, normal in volume and character, and all peripheral pulses could be palpated. Blood pressure was 140 over 90 millimeters of mercury in the right upper limb in sitting position. Respiratory rate was 20 per minute, abdominothoracic type. Saturation was 97% in room air and temperature was 98.2 degree Fahrenheit. On head to foot examination, skin, hair, there was no obvious deformity found. Moving on to respiratory system examination, upper respiratory tract, nasal septum was found to be deviated to right, nasal mucosa was normal, no polyps were seen, no paranasal sinus tenderness elicited, oral hygiene was good, no tonsillar enlargement, no halitosis. Moving on to the lower respiratory tract examination, on inspection, shape of chest is bilaterally symmetrical, no drooping of shoulders noticed, trachea appears to be deviated to the right, a trail sign positive, apical
What is
impulse.
trail sign?
Trail sign is a sign the clavicular head of the sternomastoid muscle is more apparent, is more prominent, and is an inspectory finding when we examine.
So if suppose one side is prominent, trachea is deviated to which side?
To the same side.
Okay.
The apical impulse was not visible in this patient. Chest movements appeared to be equal on both sides, and an abdominothoracic type of breathing was observed. No supraclavicular hollowing or infraclavicular flattening. No visible scars, sinuses, visible pulsations or dilated veins. On palpation, no local rise of temperature or tenderness. The trachea, inspectory finding of tracheal deviation was confirmed, found to be deviated to the right. Apex beat was palpable at the left fifth intercostal space, 1 centimeter medial to the midclavicular line. Chest movements were bilaterally equal in all areas. The total chest circumference was 94 centimeter with a chest expansion of 3 centimeter, 1.5 centimeter on each hemithorax. The spinocapular distance was equal bilaterally and found to be 7 centimeter. The AP diameter of 26 centimeter, transverse diameter of 35 centimeter. The AP to transverse diameter ratio was almost 5:7. A tactile vocal fremitus was found to be equal on both sides in all areas. Since the patient was having active hemoptysis, percussion was not elicited. Moving on to auscultation, normal vesicular breath sounds of equal intensity were heard on both sides over all areas. No added sounds were heard, and vocal resonance was found to be equal on both sides and all areas. The other system examinations were within normal limits.
Okay. What is your final diagnosis from the examination history taking?
Sir, possibly a sequelae of pulmonary tuberculosis.
Like you told, cavity,
Like
cavitate relation, bronchiectasis. Okay. How do you manage this case in emergency room? Then we'll see.
Okay. Since he presented with when he came, he was not having any active hemoptysis at present in the ER. His vitals were stable with a stable BP and saturation was maintained. He was not in respiratory distress. And there was no evidence of any life-threatening hemoptysis at that time. So we proceeded.
What are the problems in hemoptysis? Which all complications of hemoptysis can produce life-threatening?
Sir, asphyxiation.
Asphyxiation is the most important thing. That comes suddenly. Patient will be in ward. Suddenly, patient can develop asphyxia of bleeding that can form a plaque and completely obstructs the major bronchus. Okay, that is the most important problem. Okay.
After making sure that the patient is hemodynamically stable, we proceeded with blood investigations to find out the blood counts, coagulation parameters to rule out any other underlying coagulopathy.
Okay. So platelet, PTN, APTT should be done. Okay.
A chest X-ray was taken from emergency.
What is X-ray primary? Chest X-ray.
It was showing right upper lobe bronchiectatic changes.
Right upper lobe bronchiectasis changes.
Changes with a cavity, sir.
Okay. Cavity with the fluid or?
No, sir. No air fluid level was.
Okay.
After that, since this patient was hemodynamically stable and since we are taking this to be a sequelae of the tuberculosis, the treatment for the tuberculosis part was continued and also hemostatic agents were given. And with that,
what hemostatic agent?
We had given Tranexa.
Okay, tranexamic acid. What is the dose?
We started as 500 milligram TDS.
Okay. Then?
He was also other management for hemoptysis such as cuff suppressants.
Okay. That is the most important thing. Cuff suppressant should be given.
Given. And his blood routines were not showing any other infection.
What should be the position of patient? Position of, you have to advise patient to lie down Right side, left side. Right side, left side. Or
affected lung should be in the dependent position to protect the
opposite side.
opposite side.
Then how it will drain? Drainage should happen. No? The problem is all these things, whatever may be the condition, if you keep the patient on affected side, that can accumulate for a long time, and sometimes plaques can be formed and it can obstruct. If the patient is conscious, ask the patient to lie down on the opposite side and cough it out. Okay. Otherwise, sometimes what will happen, patient suddenly collapses because of the large plaque which obstructs the major bronchus. But some book says the patient should be on an affected side. That may be to reduce the movement of that area. Okay. But we cannot tell which side may be beneficial. Okay.
Sir, and if with this for this particular patient,
if it is not coming down, or if the patient's hemoglobin is dropping, you are not able to control the bleeding, what else you can do?
Sir, we would go ahead with the CT scan to.
CT scan will tell you where is a lesion. How do you block it? How do you control the bleeding? Is there any way?
Bronchoscopic.
Bronchoscopic.
Tamponading of the
then
can be done. Other than that, local installation, the site of the disease can be localized.
Bronchial artery embolization. Okay, so that is a thing done in your department.
Yes.
Okay, mostly they do that. Okay, then what happened to the patient?
So this patient, sir, he was no further episodes of hemoptysis after admission, and he was managed with hemostatic agents for 2 days. Symptomatically his cough also was better.
Okay.
And he is discharged yesterday, sir.
Okay. Tell something about tuberculosis in this patient. How do you manage tuberculosis?
Tuberculosis, sir, he was a case of sputum positive tuberculosis. He was diagnosed because he was having cough since around more than 2 weeks, and he had weight loss also. So he went to a local center from where sputum testing was done, and he was started on treatment as per the NTP.
What is Gene Expert?
Gene Expert is nucleic acid PCR, a nucleic acid amplification test, and that is currently the universal drug sensitivity testing also, which
all drugs can be done tested there?
Both first line agents, rifampicin
and INH. So most of the time we get rifampicin sensitive. Rarely get rifampicin resistant. Yes. Then only you have to go for second line drugs. Okay. So Gene Expert is a standard investigation nowadays.
Yes.
Okay. Gold. There is another test called as what is it? Mycobacterium quantiferon gold. TB gold. Is that
so that is now for latent tuberculosis infections. We take quantiferon gold as well as the skin test in conjunction. Their results are
okay. Quantiferon gold is not a good test for Indians at least. It can be used in Western countries where tuberculosis is very, very rare. And Manto test, that is a skin test. What is the advantage and disadvantage of Manto test?
The disadvantage is because in India, because it is
everyone will be positive.
Will be positive.
Okay.
But
it is negative?
It is negative. We can.
It is negative what? A patient who is having mediastinal lymphadenopathy, Manto test, you suspect TB as a pulmonologist. Manto test is negative. What is your next diagnosis?
So you would still go ahead for the tissue diagnosis.
That's correct. You have to definitely go for tissue diagnosis. What are the other conditions which can mimic just like tuberculosis, where Manto is classically HIV. HIV is one condition where you get Manto will be less than 5 or near to 5. What is the other condition which just mimics like tuberculosis? Bilateral infiltration tuberculosis, sarcoidosis. Sarcoidosis is classically present with all features of tuberculosis, but Manto will be typically negative in that patient. But in India, we cannot tell like that. Many of the patients will have Manto positivity. Okay, when will you tell Manto positive?
More than 10 millimeter. After you read the skin, the site, 48 to 72 hours after instilling the.
Is it vertical or horizontal tension?
The horizontal.
Vertical. This is horizontal, this is vertical.
Horizontal. In duration is measured.
Okay. So this patient is already taking antitubercular drugs.
Yes, antidote.
Suppose it is a resistant TB. Since you are a respiratory specialist, we have to talk about resistant TB. What is a resistant TB? How do you manage, and what are the complications?
So, drug resistant TB can be either MDR TB, XDR TB. When
Okay.
MDR TB is when it is resistant to both the first rifampicin as well as pyrazinamide and the second line injectables.
Okay.
And management of drug sensitivity TB, the first step is to send the specimen for second line LPA and to determine which are the drugs that are sensitive. And then depending upon the LPA results, whether it is mono or poly resistance, the regimen can vary. One of the major reasons for resistance is because of the improper treatment or lack of adherence to treatment in the prior treatment phase. So that is one thing that as physicians we can
What is the advantage of rifampicin in the short course regime? All these DOTS regime will be short course and rifampicin must be there. What is the advantage of rifampicin? Why we are adding rifampicin everywhere? What is the reason? Emergency medicine, it is not required. TB is one condition which can come to any department. Cardiology, neurology, gastroenterology, GI. So TB, at least you should know something. Rifampicin, what is the advantage? You add rifampicin to a short course regime, and rifampicin must be there in short course regime. That is okay. That is the one. Huh? Less resistance is not a good answer. To avoid resistance, we are adding multiple drugs. Rifampicin is one drug which acts against slow growers. Okay, there are rapid growers in TB and slow growers in TB. Okay, so the problem with slow grower is what? What is known as fall and rise phenomenon in TB? What is that? What is that? What is that fall and rise phenomenon? Fall and rise.
Initial.
So if we give ITT, all these rapid growers will fall down. Okay. Slow growers, if you are not having rifampicin, they slowly grow up. Okay. So if rifampicin is not there in the regime, then what is the duration of the treatment? That is a problem with rifampicin. If rifampicin cannot be given in any patient because of resistant TB, then what is the duration of the treatment? Then you have to think about the slow growers. Slow growers slowly grow. After 6 months, they come to picture. Other things will come down. So it takes how many months?
More than 9 to 12 months.
9 to 12 months is less.
15 to 18 months.
18 months is the treatment regime. Okay. So whenever rifampicin is not working, it is now newer drugs have got better action, but better to treat this patient for 18 months. Okay. So that's the importance of rifampicin in the regime. What are the adverse effects of anti-TB drugs? You take rifampicin, INH, ethambutol, pyrazinamide, streptomycin. So the commonly used drugs, second line drugs like quinolones. Okay.
Hepatotoxicity, INH, hepatotoxicity.
Rifampicin, hepatotoxicity is classic. Pyrazinamide also can produce optic neuritis.
Streptomycin is audio.
Streptomycin, patient can have hearing defect. Okay.
Sir, other than that, some patients bone marrow suppression in
which one? Not very common. Rarely it can happen. Okay. Peripheral neuropathy. Which drug? INH. So what vitamin you are adding to the regime? Pyridoxine should be added. Okay. So what is the duration of treatment normally in DOTS regime you give?
2 months of intensive phase and 4 months of continuation phase.
Okay. What are the drugs used in continuation phase?
HRE, rifampicin.
Suppose you start anti-tubercular treatment for one patient.
Yes.
Okay. After a few days, 2 months, he is coming back with LFT alteration. Yes. What do you do? This is a common scenario in tuberculosis treatment. Patient come back with elevated SGOT, SGPT. What
Sir, if the patient is not having symptoms such as nausea, vomiting, abdominal pain, and we will check the LFT, and if it is not rise in SGOT-PT, if it is less than 5 times the upper limit of
Okay.
normal, then we can observe the patient. If it
Okay.
is more than that, we will have to stop the drugs and then re-challenge the patient.
Okay, how to stop all, should we stop all the drugs or continue some drugs? What is the,
Normally here we stop
you stop all, okay.
all the
According
drugs.
to your regime, you stop all the
All the
drugs.
drugs,
Okay,
and
correct.
then after monitoring the LFT, we will restart
After
with
monitoring, you don't know whether it is drug induced or something. That is the most important problem. So what is given in books is you stop the drugs. But if it is due to viral hepatitis, this is well explained in all textbooks. You have to rule out other causes for LFT alteration. Sometimes patient can come with hepatitis A or B. Okay, so you have to rule out hepatitis A, B, C, all these things. Then you have to restart the drugs one by one. Okay, so in a patient who is having elevated SGOT, SGPT, you have stopped all the drugs. Now how you restart?
Sir, I would like to restart with, if other causes have been ruled out, isoniazid at half the dose.
Which is most
150.
least hepatotoxic drug?
Least is
Least is what? INH, rifampicin, ethambutol, pyrazinamide, which is the least hepatotoxic drug.
ethambutol.
Ethambutol. So you can start ethambutol in full
yes.
dose. There is
Full
no
dose
issue
can
at all. So ethambutol with some other drug. What is the next least toxic drug?
Isoniazid.
INH. What is the first day dose you will give?
150 mg.
150 mg is 5 milligram per kg body is the dose
Yes.
for any patient. So you have to tell in percentage of the initial dose. Means
Half, 50% of the
according
dose.
to
That,
WHO guidelines, it is 25%. You give 25%. After 3 days, you check the LFT. Then 50%. Then again check the LFT. Then 100%. Then add another drug. Which is the next drug you start?
pyrazinamide we won't add.
When you are given a choice, I am already telling that rifampicin is the most important drug.
Most hepatotoxic is rifampicin.
It's okay. Most hepatotoxic is rifampicin, but you should most of the time whatever, like, it is all depends on clinician's experience. Most of the time pyrazinamide is most toxic, but book says it is rifampicin. But given a choice, I may start rifampicin because that is the most useful drug. Okay, if rifampicin is not producing any complication in LFT, we can finish the treatment by 6 months. Suppose rifampicin is not working properly or it is producing some defect or LFT alteration, then you have to remove rifampicin and go for pyrazinamide. Then the treatment duration is 18 months. So that is the only issue. But if you read WHO guidelines, it is given very clearly. Depending on the toxicity, you can start 25%, slowly build up the dose. All these things are given very well. Okay. And any drug can produce high uric acid among these drugs?
Pyrazinamide.
Pyrazinamide. Pyrazinamide is known to produce high uric acid. Should we treat that?
If patient is symptomatic.
Symptomatic. Most of the time it is asymptomatic hyperuricemia. No need to treat. But if the patient is already having some gout or something, you have to treat. Okay. So most of the patients, you start ATT and you advise, like this patient is having a cavitational lesion, you may advise isolation. How long patient should be isolated?
Sir, after starting intensive phase, within 2 weeks actually they become non-infectious, and by end of 2 months sputum, the AFB will also become negative. So
AFP, you go for a simple AFP or gene expert?
sir, AF.
Why not gene expert?
Gene expert will remain positive.
That is a problem. It will be falsely positive. That is most of the most of the time doctors do this mistake. They again do gene expert. Then it will be positive. That is positive because the dead bacilli are there. So should never do that. Either you do simple AFP test or go for AFP culture. Okay. How long AFP culture take routinely? How many days it will take?
6 weeks.
6 weeks. That is a problem of AFP culture. Okay. How is this patient after this?
He is fine. He's discharged, sir. He's okay.
Okay. Anything else you want to tell? Nothing. You have told everything.